All right, let's look at our roadmap for today. We've taken this massive landscape and categorized it into 4 easy-to-digest pillars. 1. Surgery and lymph nodes. 2. Chemotherapy and molecular tests. 3. Radiation and hormonal therapy. And 4. Special clinical scenarios.
So, let's jump right into Pillar 1, surgery and lymph nodes.
When a patient first gets diagnosed, they are usually presented with 2 vastly different surgical options. On one side, we have breast conservation surgery, or BCS. Think of this as a lumpectomy. The surgeon removes the tumor along with just a tiny 1 millimeter margin of healthy tissue, and the rest of the breast is preserved. On the flip side, we have the modified radical mastectomy. This involves removing the entire breast tissue, the nipple areola complex, and the pectoral fascia underneath. But, and this is a huge distinction from the brutal surgeries of the past, the major chest muscles are completely spared.
Now you're probably wondering, how on earth does a patient choose between the two? Well, it usually comes down to patient preference, and that's based on one incredibly empowering fact. As surgeons frequently tell their patients, whether you opt for breast conservation or full removal, the overall long-term survival is exactly the same. No difference. One procedure does not make you live longer than the other.
But here's the catch, and this brilliantly illustrates the constant trade-offs we see in medicine. While the overall survival is identical, the local recurrence rates are not. Breast conservation surgery actually has a slightly higher local regional recurrence rate. It sits right around 3 to 4%. Mastectomy, on the other hand, drops that risk to less than 1%, and it makes sense, right? Because you're leaving breast tissue behind in BCS, there is simply a slightly higher chance the cancer could pop back up in that specific area.
Because of that recurrence risk, BCS just isn't an option for everyone. Let's quickly run through the absolute contraindications. First up, if a patient is pregnant, BCS is totally off the table. Why? Because radiation is strictly forbidden during pregnancy, and as we'll learn in a bit, radiation is absolutely mandatory with BCS. Having prior chest wall radiation or active collagen vascular diseases, like systemic lupus erythematosus, also disqualifies a patient, mostly due to severe healing complications. And mechanically speaking, if the disease is multicentric, meaning there are tumors in totally different quadrants of the breast, or if the tumor is just way too large for the breast to get a good cosmetic result, a mastectomy becomes the only real choice.
Okay, so for those patients who do undergo a mastectomy and an axillary node clearance, they wake up with closed suction drains. These are absolutely crucial to stop fluid from pooling up under the skin flaps, which causes a condition known as a seroma. And for surgeons, there is a magic number they're looking for, and that number is 40. Those drains can only be safely pulled out when the fluid output drops below 40 cc's per day for 2 consecutive days. If you pull them too early, that fluid is just going to painfully accumulate all over again.
Now here's a classic medical exam trap for you. If you go up and ask a medical student what the most commonly injured nerve is during a mastectomy, they will almost always say the long thoracic nerve. You know, the one that causes that famous winging of the shoulder blade, but they'd be wrong. The most frequently injured nerve is actually the intercostal brachial nerve, or ICBN. It's a sensory nerve, so if it gets nicked, patients will complain of numbness or this really strange, altered sensation in their armpit and inner arm. Basically, it makes doing everyday things like putting on deodorant feel super weird.
Moving beyond the breast itself, we absolutely have to address the lymph nodes. Historically, surgeons just went in and took them all out, which led to severe, lifelong arm swelling known as lymphedema. But today we use this incredibly elegant procedure called a sentinel lymph node biopsy. Basically, we inject a blue dye and a radioactive isotope right into the breast. The body's lymphatic system naturally sweeps this up and carries it straight to the first draining node, the guardian node. Then, in the OR, the surgeon uses a gamma probe. It clicks, just like a Geiger counter, helping them hunt down this hot blue node. They remove it and send it for immediate frozen section analysis, right then and there. If it's clear of cancer, they stop. The rest of the nodes are totally safe, sparing the patient from a radical surgery and all that awful lymphedema.
All right, that brings us to Pillar 2, chemotherapy and molecular tests.
So surgery handles the local problem. But what if microscopic cancer cells have already escaped into the bloodstream? That is exactly where systemic therapies step in. Now, we all know chemotherapy is notoriously harsh, and every single agent has a very specific, high-yield toxicity profile you've got to watch out for. Cyclophosphamide is famous for causing hemorrhagic cystitis, basically bleeding in the bladder. That's exactly why we always pair it with a protector drug called Mesna. Adriamycin can cause severe heart failure, specifically dilated cardiomyopathy. Taxanes like paclitaxel are infamous for causing neuropathy, which is this terrible numbness in the fingers. In fact, if a patient is a surgeon or a musician who desperately needs their fine motor skills, doctors will often try to avoid taxanes entirely. And finally, for HER2-positive cancers, we use targeted drugs like trastuzumab. But those also carry cardiotoxicity risks, so patients have to get regular echocardiograms just to be safe.
Hearing about those brutal side effects, it's no wonder that if you ask almost any patient what they fear the most, it's the chemo. It's grueling. So we really have to ask the critical question. Is there any way early-stage breast cancer patients can just safely avoid it entirely? Well, the answer is a massive, resounding yes, and it's all thanks to modern genomic innovations. We now have these brilliant molecular tests, things like the 21-gene Oncotype DX or the 70-gene MammaPrint. For patients who have early-stage, estrogen receptor-positive, no-negative breast cancer, these tests actually analyze the exact genetics of the tumor itself. They crunch the numbers to give a highly precise recurrence score. And here's the absolute game changer. If that score comes back low, the clinical data proves that giving them chemotherapy will offer literally zero added benefit, so we can safely waive the chemo and totally spare these patients from all that unnecessary toxicity. It's just amazing.
Moving right along, let's hit Pillar 3, radiation and hormonal therapy.
Think of these therapies as our highly targeted sweepers. They are designed to mop up any lingering microscopic disease that surgery or chemo might have somehow missed. Now, remember earlier when we were looking at the recurrence rates for breast conservation surgery? Because we leave so much actual breast tissue behind in that procedure, radiotherapy is an absolute, non-negotiable mandate following a lumpectomy. Without it, the local recurrence rate just skyrockets. It's basically the golden rule of breast conservation. If you save the breast, you absolutely must radiate the rest.
Now, what if the tumor actually feeds on hormones, like estrogen? That's when we deploy hormonal therapy. But the strategy here totally flips depending on the patient's age. For premenopausal women whose ovaries are still actively pumping out estrogen, we use a drug called tamoxifen. It blocks the receptors, but it famously causes really severe hot flashes and even carries a risk of deep vein thrombosis. But for postmenopausal women, nature has already shut down the ovaries, so any estrogen they have is only being made in their peripheral body fat by an enzyme called aromatase. To fight that, we use aromatase inhibitors like letrozole to block the enzyme completely. The big catch, though, these drugs seriously drain bone density. Osteoporosis is the most common side effect, which means getting baseline bone scans is absolutely mandatory for these patients.
And finally, let's look at Pillar 4, special clinical scenarios. Let's see how all these rules apply to complex real-world edge cases, because as we all know in the clinic, patients rarely present perfectly by the textbook. Take locally advanced breast cancer, or LABC for example. These are the truly extreme cases. We strictly define LABC as having massive tumors. We're talking over 5 centimeters with positive nodes, or tumors that have literally invaded the skin, giving it this thick, orange peel texture, or even anchoring right into the chest wall. In these scenarios, the entire script gets flipped. Doing surgery right off the bat is practically impossible. So these patients absolutely must get neoadjuvant chemotherapy first, purely to shrink that massive tumor down to an operable size.
Then we have the truly heartbreaking reality of pregnancy-associated breast cancer. Trying to treat an aggressive, fast-growing cancer while simultaneously protecting a developing fetus is an unbelievably delicate balancing act. During the first trimester, months 1 to 3, chemotherapy is strictly avoided because the baby's organs are just starting to form. Interestingly, though, in the second and third trimesters, chemotherapy is actually permitted, and surgery can safely happen. But what about radiation? That is a hard no. It is completely banned for all 9 months. Radiation is entirely off the table until postpartum.
Now, on the total opposite end of the spectrum, we have DCIS, which stands for ductal carcinoma in situ. This is a pre-invasive cancer. It's usually completely invisible to the naked eye and is normally only found as tiny microcalcifications on a routine mammogram. The Comedo variant, the one with tissue necrosis, is definitely its most aggressive form. But here is the most crucial clinical takeaway. Because DCIS is in situ, which literally means it hasn't invaded through the basement membrane into the bloodstream yet, chemotherapy has absolutely zero role in its management. None. It is purely treated with surgery and occasionally radiation.
Now, there's a really common misconception out there that this is exclusively a woman's disease. But male breast cancer actually makes up about 1% of all cases. It's often linked to genetics, like having the BRCA2 mutation, or conditions like liver cirrhosis. But here's what's fascinating. Despite the obvious anatomical differences, the diagnosis, the surgical management, and the overall prognosis are completely identical to female breast cancer. Male patients are even treated with tamoxifen. And, remarkably, they complain of the exact same side effects, including those really intense hot flashes.
As we talk about survivorship, there's a very rare but truly terrifying late complication that we have to mention, Stewart-Treves syndrome. If a patient gets a radical axillary clearance and then suffers from chronic, severe lymphedema for a long time, usually we're talking 8 to 10 years post-surgery, that chronically swollen tissue can suddenly erupt into these bluish-red nodules. That is a highly lethal angiosarcoma. It's a dark reality, but it brilliantly illustrates exactly why lifelong monitoring and aggressive management of post-mastectomy arm swelling is just absolutely critical.
Well,